I'll start. With the phasing in of the healthcare reform that was passed 2 years ago, there actually has been some reduction in the cost, believe it or not, about 4% over the last 2 years. That was sort of a shocking little piece of information I picked up over the last number of weeks. The frustration with business is that uncertainty of what that premium is going to look like. If you know it's going to be $190,000, you can build it into your budget. If it's going to be $240,000 or if it's going to be $100,000, that's when it gets real dicey trying to figure out what to do. The healthcare exchanges may be helpful, but who knows? We haven't really tested those out very well. The healthcare exchange is sort of what federal employees have right now and some state employees have, where you have sort of a negotiated package that is done for a large group of people, and then you can pick different plans within that exchange. And that has kept costs down for some of those very large groups. The real concern that a lot of people have is that in order to make these exchanges work, you're going to have to bundle in a lot of the underinsured or uninsured people into that pool. And also, if you don't have a strict mandate that says you have to have insurance, you're going to jump into that pool, that exchange, back and forth, depending upon if you have a health care concern. Okay? So that means if you know you're going to have gallbladder surgery, you'll sign on. If you're not going to have gallbladder surgery, you'll say, hey, I won't need to have that deep end kind of insurance. So there's a lot of variables in here. We're not sure exactly how it's going to work, but there has been a bit of cost savings under these last 2 years. It comes in sort of a strange place, and that is in the advertising that insurance plans do. There's a little rule that Senator Al Franken put in that said you cannot spend more than like 15% on advertising. Most advertising now is down in 12 to 13% range. And so as the insurance companies do less advertising, it might be better. Let's put it that way. So if we could just get the same thing for the drug companies, life would be a lot better. But I think the real concern that a lot of people have is the issue of certainty. And most of it's going to be phased in slowly, and the states are going to be responsible for that.
I'm going to be your biggest advocate against what the senator's staff has just said.
We're not necessarily saying that we're in favor of this. We're saying that we have to give it a little bit of time here. Colin, voted against the health care reform.
Yes.
Mm-hmm.
The health insurance exchange is very costly. One of the big things that came down from the Supreme Court, now I was hoping that it would be repealed. It was not repealed. The Supreme Court ruled it as a tax instead. But the Supreme Court did say it is up to the states. The federal government cannot hold the states and say, well, if you don't set up the healthcare insurance exchange, then you're not going to get your Medicare funding. The Supreme Court has said that it's up to the states to decide if they want to put in the health insurance exchange. Now, quite a few states have said we are not going to propose this. The health insurance exchange is the linchpin which holds Obamacare together. Funding the exchange is not cheap. It's about $40 to $80 million just to operate the exchange. And the state has to start taking that payment in 2015. Until 2015, the design and development funding is coming from the federal government. But funding for this is not, it's coming from the taxpayers. So we're paying for this no matter which way we want to talk about. Now the $190,000 is a big chunk of change.
Mm-hmm.
So I can understand from a business viewpoint that how do you build that into your budget? And the exchange, we're not even sure how that's going to be funded. How is that? Is it going to be higher premiums, insurance premiums? Because in other states where there is an exchange, health insurance premiums have skyrocketed. And in Minnesota, they're already talking 23% increase in health insurance exchange, or health insurance premiums. And that's very costly. Not only costly for the businesses, but for those private people that have insurance also. I'm a firm believer that we need to open up the health insurance market, the insurance market, so that we can drive competition between the states to lower that premium, much like we do with our automobile insurance. Shop around for the coverage that you think you're going to need, that you want, instead of a one-size-fits-all type of deal that, you know, only the state of Minnesota can you shop for insurance. So that's what I am pushing for. I'm also pushing for some legislation for charity care. I think, I believe, and I know because I'm a single mom of 3 kids, health insurance is very important to me. It's important to the single parents that I see as I'm outdoor knocking. It's important to families also. I mean, as a whole, but we have to remember health insurance is not health care. No matter how much health insurance you have, does not drive the care that you're going to get from your doctors also. And when I see a lot of, we hear stories. I sit on the health committees, both finance and reform. And what I hear a lot from our hospitals and our clinics, and from even parents themselves, that, you know, their child has an earache. Sometimes they just, these are the lower income population that are on state assistance. Their child has an earache. There's something minor with their child, but they don't want to go to the clinic. They don't want to have to make an appointment and go in the next day. They're using the emergency room as they are using their primary care. Okay, that is also driving up the cost of insurance. Now, there are doctors out there that actually want to do charity care. They want to provide a service and help people out, so they're not going to the emergency room. But because of our federal healthcare laws and such, they can't do free care per se. So I'm working with a group of doctors to bring this forward. I did have a bill that I dropped last session. There's still a lot of work to do, but I would like to actually see real clinics that are free, that the doctors are running without the regulations brought down from the federal government and the state government, so that they can provide care for, you know, even if they have, you know, they want to take it as a tax credit. But if they're willing to provide their service, they should be able to get a tax credit also. So that's what I'm passionate about.
Any other comments on that?
Sorry, that was a little long.
You did good. Also in the healthcare, one of the questions that came up is that right now on the Minnesota tax return for an individual, you can get a credit if you have long-term care insurance and it has at least $100,000 coverage on it. Is there any thought to, is that going to continue or perhaps enhance it? Because with our aging population, the last thing everybody wants to do is not end up on the Medicaid provided long-term care. Quite often those facilities that have a very high percentage of, we'll say, federal or state paid residents rather than private residents, the care isn't as good as a home that has a high percentage of private paid. Is there any comments on the long-term care?
Well, I think you're referring to the tax credit that the state offers.
Yes.
Which is measly.
Yes.
It's a good start, but I have been a proponent, and several of us think that ought to go up. Anything we can do to work with or incent the individuals or private parties to buy long-term care insurance and do some planning for their long-term care needs saves the state. The last I recall was 4 to 1. So every $1 we put into a tax credit that somebody buys a long-term care insurance policy, eventually or ultimately will save the state $4 because that person and that family doesn't come on Medicaid because they've got something in place to take care of them. I think we ought to raise that tax credit if we could. It would be money well spent. Of course, the credit comes earlier and the savings comes later, and so that gets to be a little bit of a budget dilemma. And as a society, you know, I think there's been more education and talk about it, but I mean, the state at some point can't continue to be the final payer. Right now, about 2/3 of most nursing home residents are paid by the state. And I mean, if you want a glimpse of what national health care does, just look at the nursing homes and what they complain about, and you've got yourself a microcosm of what eventually national run healthcare is going to do